Hello, everyone. I'm Dr. Jessica Ailani. I'm the director of the Medstar Georgetown Headache Center.
And my name is Zubair Ahmed. I'm an assistant professor of neurology at the Cleveland Clinic Lerner College of Medicine. I also direct the Headache Fellowship here, and I'm in charge of research operations for the Headache Center.
I'm so happy that you are joining us today for the video journal for neurology. And on this episode, we're going to be discussing a wonderful article titled Patient-Centered Treatment of Chronic Migraine with Medication Overuse, a prospective randomized pragmatic clinical trial published by some of our close friends. The first author is Dr. Todd Schwett, and many of our colleagues have joined him, I think, on this very ambitious journey to try to get this study done, completed, and published. So we're going to be having a great conversation today. I hope you stick through it with us. And Zubair, I thought I'd start by asking you a question. Why is this topic of migraine and medication overuse such an important one for us to study?
Yes, so it's very near and dear to my heart, but I think objectively, we know that there are more than 1 billion people who have migraine. It's the #1 cause of disability in patients under the age of 50. It affects women who are very healthy, very active, taking care of families, working, and when they're affected by it, it completely disables them. So it has a tremendous impact on the workforce. It has a tremendous impact on family life. We also know that 8% of patients who have migraine have chronic migraine, and chronic migraine is the most severe form of migraine, as you know. And the definition of chronic migraine for us is anybody who has 15 headache days per month, of which at least 8 of those are migrainous in nature, associated with light and sound sensitivity. And for us, it's really important because we want to treat patients effectively. And to treat migraine, oftentimes patients will take as-needed medication. But this is one of those situations where a little bit can be good, but if you take too much, it can actually make your headaches worse. And so this question that's being asked by the researchers for this manuscript is one that's very, very important. We also know that up to 50% of patients who have chronic migraine are going to overuse their symptomatic or as-needed medication. So this is quite high. And we don't know the best way to treat these patients. And these patients are struggling with headaches. And we always ask ourselves, should we stop that symptomatic medication, the one that they're using as a rescue? Do we continue it? Do we continue or just add on a preventive? So there are a lot of really practical questions that this paper seeks to answer. So Jess, before we get into more details, can you tell us what medication overuse is and how it's different than medication overuse headache?
I think you've brought up a couple of great points, but we always have to stop and think about medication overuse headache. Aren't they the same thing? And aren't we using these terms interchangeably? But really, they're not quite the same thing. And I think this is what makes it so complicated when we're trying to study this subject and when we're having that discussion with patients. So medication overuse is when somebody's taking acute treatment and they're using it more than half the days of the month. And this is, they're taking simple analgesics more than 15 days a month. That's things like acetaminophen or ibuprofen, or they're taking something like a triptan greater than 10 days a month or an opioid. And this is happening for greater than 3 months. Medication overuse headache is when the overuse is causing the headache. But a lot of times we can't figure out that the headache is caused by the overuse until the overuse is stopped and the headache continues. I feel like it's a chicken and the egg problem. I always tell patients this too. We think it could be that you're overusing the medicine that's triggering the headache. But what if you're overusing the medication because you're having such a terrible headache and nothing else is working? And so it's this, what is actually triggering the cycle and is, what's causing what? And it can get very confusing in clinical practice and very difficult. Going back to what you were saying, what is the main question? How do we treat this? What's the right step to take? So now we're having a better understanding, hopefully, or I've confused you a little more of what's medication overuse, what's medication overuse headache. Zubair, can you tell our audience, why is it important that we treat patients who are overusing their acute treatment?
Yeah, so that's a great analogy, the chicken or the egg. I think I'm going to definitely use that in clinical practice moving forward. So overuse medication can be unsafe. I think that's the #1 reason. For example, if someone is using NSAIDs, we know that it can cause kidney issues, it can cause gastric ulcers. If it can actually even cause more headaches. And a lot of patients don't recognize this. You know, it says Excedrin for migraine. And so I'm using this for my migraines, and it seems like it should make sense. But if you use too much of it, then certainly that can cause problems. In fact, it can lead to increased disability as their headaches get even more severe. In some situations, in the case of opioids, it can lead to dependency intolerance, which is a big issue. For us, you know, if overuse is the cause of their headaches, discontinuation is an important part of reducing headache frequency, or so we thought. And getting patients to a healthy lifestyle might hinge on what we do with the medication that they're overusing. So now that we're treating patients with chronic migraine and medication overuse is important, for this study, what was their objective?
Yeah, so the study has a pretty large objective. They wanted to try to answer a pivotal debate in headache medicine. You know, us headache people, we are nerds beyond belief. we really, I would say we nerd it out in every which way you can. And one thing we often will discuss is this idea of, do you treat medication overuse just by preventing the migraine better or withdrawing the overused medication? So they wanted to look at, can you start prevention, leave the patient on their acute medication as is, and allow them to continue to use it as they want? And is that non-inferior to starting a prevention, changing the acute treatment, and then limiting their use to 2 days or less per week, a bit more of an aggressive treatment plan? Are these similar to each other? So in order to consider this questions, the authors designed this study as a non-inferiority trial. Zubair, why does this make sense for this kind of study?
And this trial design works well in this situation because this study is not necessarily aimed at showing the superiority of one treatment or one treatment paradigm over placebo, but rather showing us that, look, there's more than one way to treat medication overuse. So the study objective is really a difficult question to answer. Can you review the study design for us?
Yeah, so it was interesting. It was a multi-center US trial, and it involved headache centers, but also looked at general neurology groups and primary care to recruit adult patients with chronic migraine who are overusing medication. And I really liked the fact that primary care and general neurology was included here because, listen, we all know there are not enough headache specialists, and that patients with headache disorders are coming from all walks of care. And so I thought this was really well done on the study's behalf. They also looked at patients from February 2017 to 2020. Usually I don't take such a close look at the dates, but you know, Zubair, this is pivotal because this was a time we are exploding in the field of migraine, and these dates are very important. We did have some new treatments come about during this time period, but we know in a clinical trial, if new treatments are coming about during the time process of a trial, they might not make it into the trial. So it's unclear if, you know, when we looked in the trial, many of the patients were on really the standard of care oral treatments or older treatments and on a botulinum toxin. I actually think that's interesting, but it's an important part of consideration in the trial design. This was an open label, pragmatic clinical trial. Again, going back to that non-inferiority concept, it's not a placebo-controlled trial. We're trying to ensure that these two types of treatments, one isn't better than the other. There's more than one way to do things. So patients were placed on treatment that was considered appropriate by the clinician. They weren't forced that this many patients had to be on preventive A, this many had to be on B. I thought that was really nice too. The clinician and the patient had a choice about what was best for them. The preventive medicine wasn't necessarily forced on them. They could be on a variety of options, very close to clinical practice. There was randomization, however. It was 1-to-1, and this was switching from the overused medication to the alternative use, less than 2-day-a-week acute treatment that fixed, you know, you have to change your acute treatment and you can only use it a fixed number of days, or you can continue to use your current overused medication as you like it. That was the part that was randomized, and that was just so that they could have enough participants in each part. And this was a 12-week trial. So Zubair, can you tell us what was the primary endpoint?
Yeah, you know, I really liked this part of the study. I felt like it was relatively straightforward. The primary endpoint was moderate to severe headache days, and they define that as a headache which lasted at least 2 hours of moderate intensity. And they essentially just looked at the frequency of these headaches between weeks 9 and 12. And they also looked at moderate to severe headache day frequency during weeks 1 to 2 after randomization. And, to be honest, that headache frequency within 1 to 2 weeks after randomization is pretty quick, Jess. So what do you think, why do you think it's important to see a change in the first 2 weeks after randomization?
Yeah, I know. Sometimes in clinical practice, we aim far in advance. We tell them, oh, you got to hang in there. You got to wait. You're overusing. Give me 2 months. But when I tell patients that, the look on their face, like, no, I can't. And I don't blame them. It's a struggle. They're overusing because it's a struggle. And to tell a patient who's in this struggle of terrible pain and disability that, you got to hang in there for 12 weeks, it's very unlikely they're going to hang in there. So I think the idea to add that option of let's just see if there was a change in the first 2 weeks, and if there's a potential for improvement that we can now relay to our patients, that kind of data, which we haven't really had any information like that, that's really important. It adds that layer of hope. It encourages the patient to continue to hang in there. That faster results, that really helps them with that disability that we need to see improvement in just to get that patient to keep going. And it also allows the patient to stick through the side effects. I mean, in our field, we often say, especially with traditional medication, the first few weeks you get all the side effects and none of the good stuff, and then you get the good stuff, and all. And by then the patient has given up and left the treatment. So I think it's important, if you see any changes in those first few weeks, the patient's going to be more able and willing to stick it out. So yeah, speaking of the patients itself, Zubair, tell us a little bit about the demographics. I think particularly in this trial, the demographics is going to be important if we're going to try to relay that to clinical practice.
Oh, absolutely. So they randomized a total of 720 patients into the 2 treatment arms, the ones that you described earlier. The average age of the patients was 44, which is pretty consistent with my clinical practice. About 88% of patients were women, 75% were white. Most were overusing simple analgesics, but opioid and butalbital overuse was around 10%. Triptan overuse was around 20%, so 1 in 5 patients. Again, I think, and I think you'd probably agree also, this is pretty consistent with the migraine patient population that I see in clinic. Mean headache days were 21 days per month, of which about, I would say half of them, a little bit more than half, 12 to 13 were moderate to severe headache days, the ones that I defined earlier. Again, very consistent with what we see in clinic. All right, Jess, so no more suspense. Tell us what they found.
Yeah, so they actually had, I thought, pretty impressive results. A migraine preventive medication without making switches of the overused acute treatment was not inferior to preventive medication when you did switch for moderate to severe headache day frequency during weeks 9 to 12. And similar outcomes were seen in the first 2 weeks. So I think they met both of their outcomes. I was most impressed by the first 2 weeks, though, because again, to me, that allows me to change my little statement to the patients where I tell them, give me 2 months before you're going to get better, and say that you can start to see improvement that first 2 weeks. So hang in there. I thought that's pretty good stuff. What do you think? What do you think some of the strengths are of the study?
Yeah, I agree with you. I think it's very practical. I think it gives patients hope. Those are really important things. The main strengths of this study are that it makes the clinical approach to treating patients a bit simpler, right? So there's less stigma to the patient and the potential that for many patients, not much more than addition of a prevention is needed, or at the very least, optimizing the preventive that they're already on. In clinical practice, it may be faster to implement as well, and it's definitely more patient-centric, and I think that's really important. Oftentimes we see that in clinical trials, we only include patients who have mild disease. And I'm often left wondering if the results are generalizable or applicable to my patient population. So I liked how they really included a diverse patient population from, as you mentioned, primary care offices, neurologists offices, and headache specialists. And again, the primary advantage of this is that data, it feels, is generalizable to the population that I see in clinic. So those were some of the strengths, Jess. What do you think are some of the limitations of the study?
Yeah, I do think there are a couple of limits. And I think these limitations, I have to say, they're really they're nitpicky. One is the patients didn't use a diary to record headache frequency and during the baseline run-in phase. A lot of it was recall, and recall can definitely present a bias. I do think, though, a lot of times in my own clinical practice, recall bias tends to run the opposite way when it comes to overuse, that patients tend to underreport their overuse rather than overreport, and they tend to forget to report use of over-the-counter treatment. So it is possible there was more overuse than was actually reported. Though when you look at the numbers here of headache frequency and frequency of moderate to severe days, it's pretty high. And like I said, what you see in a headache clinic. So it is nice that they had a high number of primary care, but it's a pretty tough population for primary care and general neurology to be dealing with. The data is limited to 3 months, so it is hard to make long-term conclusions on the data. And they didn't really include discontinuation of symptomatic medication as even an option. So what about the patients who we tell, just stop your acute treatment, start prevention, let's see how you do after the first 2 to 3 weeks, and then we can take it from there. That arm didn't exist. So we don't know if that potential arm might have a different outcome than these arms. Now, in my clinical practice, and this is very particular, I do see a lot more triptan overuse. But when we look at the data here, 20%, as Zubair said, 1 in 5, that is very typical of the general headache patient population with medication overuse. It just happens to be in a headache practice in my region, triptan overuse tends to be the predominant. So I don't know how applicable this would be to what I'm seeing in my practice, but I happen to think this is still a good way to practice. The opioid and butalbital use, again, I don't really see opioid overuse. It just happens to be the region I'm in, and we're under a lot more restrictive management issues. So I think that's a good thing, but I do see, on the other hand, a lot of butalbital overuse. And we have seen changes over time in the allowance or the restricted policies in clinical trials where butalbital overuse is just not allowed in clinical trials. So I often wonder, how would these patients do with medication overuse? And in this particular study, the opioid butalbital group was combined. So it's harder to say, were they more opioid overuse? Was it more butalbital overuse? How did that group do if it was heavily more butalbital versus opioid? I do think it's a limit, but it is, again, like I said, big time nitpicking. So Zubair, do you think these findings would be applicable to all the patients with medication overuse or just some of them?
Yeah, that's a really good question. So according to the results, it looks like patients who have a high degree of medication overuse, high degree being more than 23 days where they're overusing their symptomatic medication or their rescue medication, they might have better outcomes if they are switched off of their overused medication. However, those patients who have comorbid anxiety or fewer days than the 23 that I mentioned of rescue or symptomatic medication use, they might be better off without switching their rescue treatment.
I think that's it's a very valid point. Actually, something I really liked from the study was there's a little part. It's like I would tell my residents and fellows, cut this part out, paste it on your wall kind of thing, where it gives you kind of a bar to say, okay, if it's this, then do this. If it's that, then do that. And I tend to agree with this. It's those that are overusing every day, you really have to set some limits. But if they're not overusing every day, you can tell them, okay, let's just get you on a good preventive and take it from there.
Right, and it really speaks to your point earlier that a lot of patients might be underreporting the frequency at which they're using, right? So that's a really good mark, because that person who says they're using it 23 days, they may be using it even higher. So absolutely, I totally agree. After reading the study, do you think the findings from the study change your clinical practice?
I think it really depends on the treating clinician. I think that, if I was a primary care provider or general neurologist, one of the main takeaways here is really make sure the patient's on preventive treatment. I think that is number one. If I don't have the time or the ability to really have this whole conversation about reducing overuse, that's okay. Let's just get them started on prevention. We'll deal with the rest of it later. If I'm more a neurologist that's very vested in headache treatment, which many general neurologists are, or I'm a headache specialist, then I might really get into the details of, listen, you're overusing every day. Let's try to set a little bit of boundaries while we are at the same time aggressively getting you on a preventive regimen. That's something I think I've already been moving my practice to over the last 5-6 years. So part of why I think I love this study was like, yes, I've been doing it right. But like I said, it's been a debate. So for those of us that have been on this side of the debate, finally having something that recognizes we have been somewhat doing this that right way, it's a really good feeling. Otherwise, you've just kind of been out there doing it your way, feeling like, well, it seems like it's working in my patients.
Right.
What is the patient comfortable doing? If I can get them to just stop overuse, which sometimes when you have a very open dialogue and you get them to talk to you about why they're overusing and it's anxiety versus why they're overusing and it's, well, I just didn't have a good no one's brought up prevention before. I like this concept. Why not stop it before it gets this bad? I don't want to use this as needed medicine anymore. It wasn't really working that well anyway. It really helps you like figure out with the patient which way you're going to go. But that does require a little bit more time. So I really think, what you're going to do, this gives you, depending on the time you have and the type of clinician you are, options. And that I think is really what's amazing. So we've seen a lot of evolution in our field and also a lot of evolution in clinical trials, especially migraine, especially looking at medication overuse. Some of our newer treatments have allowed patients with medication overuse to continue into the trials, looking at like CGRP monoclonal antibodies and onabotulinum toxin. But we've never really looked at older drugs, and their impact. And now we have this information. Do you think now having information like this, which shows that medication overuse and not having to change might not be inferior to forcing medication overuse to stop, do you think this might impact the design of future migraine trials?
Yes, I think it will. This highlights the right thing, right? There's no wrong answer in this situation. So I think that's important because oftentimes in clinical trials, we do exclude those patients. But now that we know that we can continue them on the preventive that they're on, and oftentimes stability of the preventive medication for at least 3 months is something that's required by the inclusion criteria. So again, I'm hopeful that it will change the way we look at patients who have medication overuse. I think it's just another way to highlight the importance of this topic in general. Oftentimes we're looking at the new and best way to treat patients, but this trial just highlights that, look, it's important to get folks on a preventive. And again, this, while it may not explain the whole story, it just shows us how important of a piece of the puzzle it is to get our patients better. Jess, were there any results from this study that surprised you?
Yeah, I think I've mentioned the idea of making it easier to be on prevention. I think the reason we're saying this is one of the surprising results was that only 56% of patients were on a preventive. And that's surprising because these are patients with chronic migraine, with medication overuse. These are people that are struggling, and so we are all trying. And I think we need to keep trying to get these patients on prevention to try to get them with less disability. Also surprising was that even though patients in this trial got on prevention, that they still struggled, that they were still having frequent headaches towards the end of this trial at 9 to 12 weeks. They were still having significant negative impact from headache, and they were frequently using symptomatic medication. So this really shows us how treatment resistant chronic migraine with medication overuse can be. And I wonder if this almost does answer my chicken, the egg question in the first place, which is, perhaps this might be the egg or the chicken. I still think the egg might have come first, but the idea that the disease is so refractory, hence the patients need to overuse the treatment, and that it's not that they're overusing the treatment and that makes the disease refractory, and that we need to come up with more and better options for these patients, prevention that works in a different manner, that the disease is really taking away from these people. And hence, even if they're better, they're still not quite great and they're still struggling. So are there some future studies, Zubair, you would hope to see in patients with medication overuse?
Yeah, this study is definitely hypothesis generating. So we now have data that suggests that treatment with some of the older or even newer preventive therapies in those patients with medication overuse without changing their acute medication can be effective. But we still don't have enough data on those patients who are overusing opioids and butalbital. I had a patient earlier in clinic who was treated with butalbital. And as we see the population of patients who overuse butalbital continues to rise, we need more studies in this patient population. And it's really helpful for us to identify what are the more effective strategies in managing patients who are overusing butalbital. And we both know how dangerous that can be. The message that they can continue with overuse without withdrawing their symptomatic medication is probably not the right message we want to send them, right? So I think that's definitely important. One of the points we mentioned earlier was that patients with comorbid anxiety and medication overuse might do better if their overuse medication isn't changed. So why do you think that might be?
Well, I think anxiety plays a very large role in medication overuse. There's definitely the population with medication overuse that the disease is refractory, period. And that's plays a role in the medication overuse. But then there's a population, a subset, that anxiety is driving the medication overuse, anxiety about the disease, anxiety about life, anxiety in general. And it could also, it's one of those things that rolls in together. They're anxious and they're anxious about the disease, and they overuse as a way to manage the disease and have some control back. And, one, we need to treat the anxiety to help with some of it. But two, imagine that you're anxious and your only source of control is this acute treatment, and you're taking that away and not supplementing with anything to control that anxiety. That in itself is very panic producing and can be very detrimental to that process of improving their reduction in disease and trust and improving disability. So, the authors recognized that, and they felt that changing rescue treatment in some patients can really compound anxiety, and that in a certain subgroup of population, it might be best to continue their current rescue, especially if the patient feels it's effective and that they're relying on it, and to ask potentially to limit their use of that acute treatment. And I definitely agree in clinical practice for certain acute treatments that I don't consider to be dangerous, or the patient isn't using it dangerously, then I might continue it with certain limits put on it, and at the same time start to treat anxiety and put them on prevention. So Zubair, as we wrap this program up, any final thoughts?
Yeah, a couple things, and again, it's what we've touched on earlier. I just loved how practical this study was. And it's very patient-centric, and again, I really enjoyed that aspect of the study because it really applies to our patient population. One of the things that I thought was really interesting was that they mentioned in the article that the most common reason that potentially eligible patients were not randomized was that they were unwilling to be randomized to the treatment strategy that required switching that overused symptomatic medication. And that's really interesting because that's the question that the study was designed to answer. And it just, again, emphasizes the importance of including the patient in this treatment strategy, listening to them. And now the study shows that patients may not need to be switched. So they have this fear, and we realize this fear, and they don't necessarily need to have this fear. We can keep them on the rescue treatment. So again, it really just emphasizes the importance of developing trust with the patient. And I personally feel that this point cannot be overemphasized. Migraine and medication overuse are really complex. We both know that. At the end of the day, it's really a trusting relationship between ourselves and the patient that's going to lead to the best possible outcomes.
Yeah, I think you couldn't have said it better. I think that we've learned a lot from this study. I think we've got a lot more to learn in general about how to better manage medication overuse, not necessarily how to treat it, but how we can maybe avoid getting into that pattern in the first place. But I really want to thank the authors for this endeavor that they've undertaken and the wonderful outcomes, and very patient-centered outcomes indeed. I think that I'm very hopeful we have a few more studies in the future looking like this. These patient-centered outcomes really help us in clinical practice and bring home the things that we're doing are the right things that we're doing for our patients. And I think it really leads to better partnerships with our patients. I want to thank you for joining me and thank our audience for listening along. I hope you've enjoyed this episode of Neurology Video Journal, and I hope you read the article. It's absolutely fantastic.
Thanks, Jess. I appreciate it.
Bye, everyone.